so that both you can go back and listen to this, and those who couldn't join us live can listen to it later. So, Kurt, I'm going to turn it over to you.
Mm-hmm.
Curtis? Kurt, over to you. Had a little lag there for a second.
Yes, I'm here. Hi, everybody. Good morning. Such a pleasure to be here. Thank you, Maura and MindUp, for hosting this. And I think also a very important thank you is due to them for being willing to open this up to other people. So I'm happy that we have a nice group here. I will tell you a little bit about me and then we'll dive in. I'm Curtis. I'm American. I split my time between Portugal and the United States, but I previously lived in Tel Aviv. By profession, long ago, I am a health systems researcher. So that was work that I did with at the Harvard School of Public Health and at Columbia University. But I've been working in high tech for the past, 12, 13, 14 years at this point. I ran some nice music. I helped set up a venture design studio in Tel Aviv. I oversaw a product at a software as a solution health tech company. I have board level experience. And for the past 5 years, I ran my own consulting and advising firm, primarily working with early stage health tech companies and their funders. So we don't have a ton of time today, but we do have enough time to give you some good tips and tricks and get you started on thinking about how to begin selling into US payers or insurers. I'm going to go ahead and share my screen, and we will dive in. Can everybody see my screen? I see nods. Thank you. So we'll try to make this interactive and a little bit fun, demonstrating value for US payers, or as I like to say, show me the money. We know that US healthcare is a business, so it's about the bottom line. Not exclusively, but primarily. Oops. So what we'll cover today, we'll just run through the goals of this workshop, just to sort of level set. We'll talk very briefly about the business of American healthcare and how those financial incentives work. And then we'll really talk through how to begin estimating your solution's influence on cost, along with some tips and tricks. Okay? So what would I like to help you with today? Really to better engage US payers around partnership or purchasing by allowing you to better define or calculate your value to them. Now, I understand that we have people who are at different stages of their entrepreneurial journey. So you might not be ready to do this. You might still be doing, prototyping, MVP, getting to product market fit. That's okay. If you're not at that point, it's really still important for you to begin laying the groundwork for you to be able to do that, to have those conversations. And you'll make your lives much easier if you start sooner. In case it's not clear, why should we really care about demonstrating this value? Most startups within healthcare in the United States will work with payers or employers to achieve scale. So we absolutely have successful and highly scaled direct-to-consumer health tech offerings. I'm not saying that they don't exist. I'm not saying that they're not amazing. However, if we look at health tech startups as a whole, we see that most of them end up working with insurers or with the formal healthcare system in some way. So I would encourage you, even if you're thinking direct to consumer, if that's your plan, to still keep an eye on this. It's not unusual that I have clients who launched direct to consumer in order to do product market fit, in order to generate traction. It's where they can sort of get the most feedback from users as quickly as possible. And then at some point, they will decide to either pivot or augment their direct-to-consumer strategy with the B2B approach. Sometimes that transition is easy for them if they've thought ahead. Sometimes it's really difficult for them if they hadn't had that on their roadmap. So I would encourage you, even if you're really thinking direct-to-consumer, it's still worthwhile to keep an eye on this to keep your options open. And because we have an hour today to do this workshop, let's be realistic. You're not going to end the workshop with a fully constructed model that has all of your assumptions and variables within it to estimate cost savings. This will give you a starting point. My goal here is to allow you to begin asking questions and thinking about it and sort of begin that conversation internally. So I hope you don't mind, but I wanted to check in a little bit with you even before I get into the content. I see a lot of faces here. I see a lot of different participants, and I would actually love for people to just take 30 seconds and drop into the chat sort of where you are in your journey and really what questions you have around this, or sort of what's your motivation today for joining this. That will be helpful for me to sort of focus on our content that I have. As you're putting that in the chat, you're also welcome. If you don't want to share that with everyone, you can also just send it to me as a direct message as well, just so I have a sense of who I'm speaking to. Thank you, Olivier. That's helpful. That's great, Nimrod. That's excellent. We've got stealth mode. Great. I see a femtech company. This is a special priority of me in my work, so I'm happy to see that, Sharon. Iran, this is great. Economic value for insurers, reimbursement. That's lovely, Helen. Okay, this is really helpful. Thank you, everybody. You're welcome to continue putting things into the chat. I will keep going. What I'm hearing overall is that we have some pretty early stage folks, and people generally want to figure out how to sell into various payers. So that's good, because we're in the right place. You came to the right place. I'm in the right place. Let's dive in. I have a pop quiz for you. What are the primary drivers of decisions to purchase or partner in the US healthcare market? Is it because they like the vibes of your CEO? Is it because your VP of sales bought them a really lovely dinner? Maybe you have a beautifully produced patient testimonial and everybody who watches it on your website is moved to tears. You perhaps have an incredible RCT that you did with the Technion or Harvard or Stanford or MIT or a leading research institution. Or you'll make her save them money. So I'm being a little bit silly here. The purpose of this call, as we know, is to really talk about the bottom line. However, all of those other factors are important too, right? So we will focus today on the money piece. It's not to say that other things aren't important, right? Establishing relationships, being collegial and professional, having great clinical evidence, being able to tell a really beautiful and moving story about your solution. Those are lovely things. They're important things. I would say they're even critical things. However, within the US healthcare system, the actors are highly incentivized to consider the bottom line. So remember that as we talk about money, it is not at the exclusion of other things. It is complementary to them. And one thing that I always like to say is that as we talk about economic analysis of your solutions, even that doesn't really fully capture the impact of them. So I always like to remind us that, behind dollar figures, when we talk about this, are real people. I come from the background of health as a human right. So I used to work at a Center for Health and Human Rights at Harvard. I really believe that everybody has a right to healthcare. That is not how the US system is structured, unfortunately. So we can have that value, we can have that principle and that belief, We can infuse that into our offering that can motivate us and inspire us. And as we work within the US healthcare system, we have to remember that it is not a system that is based primarily on equity or access. That is not to say that people that you interact with do not share those values. They might be very motivated by, access to healthcare, by equitable healthcare. They might be really moved by improving patients' experiences. All of those things are present within those actors, and they are working within a system that remains very bottom line oriented. So a lot of times the thinking is, the framing that I want you to consider is, I have someone at this US payer or this US insurer, and they share my mission, they share our values, they share our inspiration. And I have to help give them the evidence that they need to convince their internal stakeholders that this will be good for the business's bottom line. Okay, this is a made-up slide. I created a fictitious disease and a fictitious company to give you an example of what I will often work with clients to develop in order to show an American payer. I created a random company, it's called Rando SAS, and I made up a condition called randothysteria. So this is really just to give you a sense of sort of what are you driving towards when you start having those conversations. This is a snapshot of the end result of that thinking, okay? So this is something that someone might take into a conversation with an insurer or an impayer and walk them through. So I'm going to do that for you right now, as though I am the CEO of Rando SAS, and I'm presenting to, let's say, I don't know, Blue Cross Blue Shield, Michigan. And I'm going to tell them, our solution is really important for you because we know that patients with randothysteria are highly costly to insurers. And in fact, we're able to show that our solution, Rando SAS, can lower the direct cost that you have. We have fantastic evidence that shows that our solution, Rando SAS, has been shown to reduce the average annual number of emergency department visits for randothysteria patients by approximately 10%. Furthermore, by reducing these related visits to the emergency department, this means that we can save payers or insurers like you an estimated 5 to 10% annually of the total direct cost for your randothysteria patient. And if we want to talk bottom line, what you should understand is that for the average randothysteria patient, this means that we can give you estimated cost savings of roughly $200 per patient per month, which is approximately $2,400 annually. I want to take that back up to the big picture. You have an insured pool of 100,000 patients, and we know that randothysteria has a prevalence of approximately 6%. So if we take that $200 per patient per month, or $2,400 annually, and apply that to your pool of 100,000 lives with a 6% prevalence, what we can give you annually is an estimated cost savings of $14.4 million US. Now, I'm back to being Curtis again, not the CDO. What I've just shared with you is incomplete. Meaning, if I was truly doing this for an insurer with a client, this would be one slide of many, right? So there would be probably some slides around baseline costs. There would be some additional slides citing research. We might dive into how we calculated this. We might share some results of our clinical trial that we are using to estimate this cost. You would probably see some footnotes where we've cited sources. So I don't want you to look at this and truly think that this is the final polished package that is the totality of making this case. But I want to give you a taste of it and an idea of what this looks like, because this is sort of where you are trying to go with this kind of work. Does that make sense to people? I'm just going to pause for a moment and check in. I see nods, I see thumbs up. Great. Okay. So this is where we want to go. Now the question is, how do we get there? We have a few different mechanisms that we can use to influence cost within the American healthcare system. This is not exclusive to the US healthcare system. These factors also apply in other healthcare systems. We're just focused on the American system right now because that's typically a market that people are quite focused on. So how can we do this? these are some of our options. We affect quality of care. By improving quality of care and the associated measures, for example, the HEDIS or STARS measures, it can allow insurers to have better reimbursement numbers. Okay, so that's one way. We can also improve efficiency, right? So healthcare systems are large operations. So we can improve their operational efficiency and decrease operational costs. That's another way to save them money. We can decrease costs or use of services or treatments, right? So we might allow our solution might allow them to provide alternate or improved treatment options. It might allow for there to be a decreased duration or required dosage of an existing treatment. It might improve adherence to a treatment or service, which allows it to be more effective, and that saves money. It might help the patients avoid costly health events. So this was the example that I used with randosas and randothysteria. We avoided emergency department visits. We know that those are highly costly. Other things that are highly costly, surgeries, things like that, right? Anything that really hits the insurer at their bottom line. And we can help avoid those through prevention or alternate treatments. And the last one is new or expanded services. So we can think about cost savings, but we can also think about revenue drivers, new ways for them to make money. So maybe your solution allows them new opportunities for revenues, new services, new markets, new patient populations. I'm going to pause. Any questions around our mechanisms to influence costs? I'm curious, do people have a sense of which of these might be easier to make a compelling case to a payer? Any guesses?
Increasing revenues.
Yes, that's a good one. Very, very good. I also see here in the chat from Nirod, avoiding costly health events. Yes, yes, very good. Decreasing costs. Yes, absolutely. All spot on. I would say, in my experience, the ones that are most difficult to demonstrate to payers and insurers are efficiency. That's really tough. It's not to say that it isn't there, but that is often a tough place to put a bottom line amount on. And quality. Quality is a tricky one within the US healthcare system. Explaining how quality measures work with insurers and payers and HMOs is really outside of the scope of this presentation, because we could spend an hour on that and more alone. But I think the thing I would say about that is that it's absolutely a place where you can identify cost savings or increased revenue for insurers. If that's where you're going to try to make your focus as a startup, I would encourage you to think deeply around those quality measures and really pull that very strongly into your clinical trials and the pilots that you're doing.
And Curtis, if I may ask, what about avoid the costly health events, which is also on the section of prevention, which somewhat is complicated for the US market, payers at least?
Yes, it is a great point. So we'll get to this a little bit at the end. I like where your mind is going. Avoiding costly events is something that has a time limit on it. What do I mean by this? If you're able to avoid a costly event for a group of patients within a year, amazing. That's how we know that's going to matter to a US insurer or payer. If you're going to tell them that you're going to, through your solution, avoid a costly health event 5 years down the road, 10 years down the road, it's unfortunately not particularly compelling to most US payers. The reason is because we know in the US market that people change insurers quite regularly because it's typically tied to their job. So basically what you're telling them is, why don't you make an investment in your patient and someone else is going to get the return on it. Now, I don't like that. That is a great example of where the American healthcare system is disincentivized to provide good care. There are some mechanisms that have been introduced with the Affordable Care Act to sort of try to incentivize preventive care or require it to make sure that that's happening. So That's a place where if your solution touches on some of those, it's worth looking at. It is currently going through the judicial system and being unfortunately dismantled. So that's something that if that's where your solution is looking at, I would encourage you to pay close attention to what's happening with that legal process. But overall, I want to get your name right, Sharon. It's a great point, which is avoiding costly health events is something that is relevant on a short time scale. Okay.
Cool. Thank you.
Any other questions about this slide before I keep going? Okay. Oh, I see a chat. Can you repeat what you said about what's changing at the judicial level? Yes. So within we have the Affordable Care Act that was passed, wow, almost a decade ago at this point, also known as Obamacare. One of the things that it did was it required HMOs and insurers to to provide preventive care. And one of the goals of that was to try to address actually this perverse financial incentive that we just talked through, where an insurer wasn't financially incentivized always to provide preventive care if the return on that preventive care was something that happened down the line, because they knew that that patient would likely be with a different insurer. So what the Affordable Care Act tried to do was to say everybody has to provide this base level of preventive medicine. And so that way everybody's playing by the same rules. Everybody has to provide this. So even if a patient moves to a different insurer, I know as an insurer that the new patients that are coming to me also, in theory, got these preventive services at the other insurer. So that was what was set up. What has now been happening really within the past 5 to 7 years is we are seeing legal challenges to the Affordable Care Act. So it's going through different judicial processes where they are basically working to remove certain aspects of that regulation. And one of the things that just came through was a dispute to the requirement that insurers cover preventive medicine. I will say I'm not an expert on this health policy, so you should take what I say with a grain of salt. But my understanding of it at this moment is that that aspect of the law has been struck down by a lower level court. However, it will probably be appealed, and so it is making its way through the American legal system, whether that provision of the Affordable Care Act will be upheld, meaning everybody still needs to provide preventive medicine, preventive services, or whether it will be struck down, meaning that not all insurers will be required to provide that. The one thing I will say about that, just to make it even more complicated, of course, is that the Affordable Care Act is a piece of federal legislation, and states often have their own legislation. So even if that piece of the Affordable Care Act is struck down at the federal level, there may still be other individual states that are still requiring that or incentivizing that in other ways. So just to make things a little bit more complicated for you as you think through market entry in the US and how you engage with that. Any other questions about that? Okay, we'll keep going. So if we're trying to think through how we get to a beautiful set of slides that help us demonstrate to an American payer how we're going to save them money or increase their revenue, what's the starting point that we begin with? And I would say that a great place for you to start with your team or as a co-founder is to come up with a theory of change. And a theory of change is really simple. It's just a sentence or a set of sentences that describes a narrative for how you will improve costs. Okay? So I always encourage people to think of this as an MVP, a minimum viable product, meaning you might brainstorm several theories of change. You might have one that you think is a good theory of change, and as you continue on your entrepreneurial journey, you might identify that you need to revise it or improve it or change it. And that is a great thing, right? You improve your product and you can improve your theory of change. So I'll give you an example theory of change that I wrote back for our Randolph Hysteria and Rando SAS solution. So I wrote a theory of change that says our solution reduces the likelihood that patients with Randolph Hysteria will go to the emergency department by identifying high-risk situations sooner and funneling them to appropriate care before their situation escalates. Now, you might recognize something within this statement, which is that it almost sounds like a company vision, or it almost sounds like a mission statement. And it kind of is. So you might actually have already in your pitch deck, in your website, in your business plan, something that sort of is a theory of change. So it's oftentimes something that you don't need to invent from scratch. It's a good starting point. I'm going to pause for a moment. I'm going to catch up on a question from the chat. And while I'm paused, I would truly encourage you to take a moment and actually write out what you think a good theory of change for your startup might be. Ifat, I'm seeing your question. It's a complex one. So let's see how we're doing for time. And at the end of the session, if there's time, let's go back to that, okay? So let's imagine you now have a beautifully written out theory of change. What's next? I like to start putting numbers on it. So here's where I've actually identified figures or assumptions that I would want to use for my Rando SAS solution. So you can see here, our solution reduces the likelihood that patients, and I said here, actually, there's a figure there. It's a % reduction in emergency department visits by Randolph hysteria patients. Similarly, we've said it's going to be patients with Randolph hysteria. So that means we better know what's the prevalence of Randolph hysteria in the general US population. Or maybe we're looking at a specific population, for example, the Medicare Advantage population. This is an older population in the United States with people who are retired. So they are older, they have a different epidemiological profile of conditions. So it might be that I'm targeting that market and I'm targeting those insurers. And so I want a prevalence that is specific to that population. I said that our patients will be less likely to go to the emergency department. Great. What's the average cost of an emergency department for a Randolph hysteria patient? Is it the same as a typical ED visit? Is it more? Is it less? Does it involve inpatient care? You know, do they go to the emergency department and then they're admitted to the hospital? Do they go there, they get, I don't know, an infusion, an emergency treatment, and then they're back home? And I've also identified that we will funnel them to the appropriate care before their situation escalates, which begs the question, what is the estimated cost of the appropriate care for them? Because that's something we need to consider when we think about the bottom line. There's a figure that's missing from this. Does anybody know what it is? Helen?
The cost of your service.
Yes, exactly. There's nothing in here about how much what you're offering is going to cost the insurer. So I would say that this is a great place where you can think about how you're going to price out what you're offering, because you may find that what you want to charge insurers eats into all of the cost savings or the increased revenue that you're expecting to give for them. And if that's the case, that's a very hard sell to make. So one of the things that I do a lot of times with early stage companies is we'll actually build a model for them, and then we will experiment with different ways to price their product. So this is a place where doing this sort of economic analysis of your solution can really inform your business strategy as well. You know, are you going to do an annual fee? Are you going to do it per patient per month? Are you going to do some sort of split cost savings? Like, how do you want to structure this to the insurer or to the payer, so that they feel like they're really still getting a great deal? Any questions on this before I move forward? Great. So you have a theory of change, it's your MVP, you've sort of identified some figures or assumptions that you need to start sort of plugging into it. I would say the next thing to ask is what figures or data are we missing? Particularly, what factors are really going to strongly influence costs? So, for example, you might build a model and you might realize that something that you think is really important actually isn't the cost driver. I'm trying to think of a good example with our Rando SaaS case study, let's call it, what if we were to determine that actually the appropriate care for a rhandophysteria patient, instead of going to the emergency department, is actually just as costly as going to the emergency department, right? So we might think that actually that's not going to be so critical. It's not a great example because I can tell you from experience that it's very unlikely that you would ever have a scenario where someone going to the emergency department is going to be as costly as other options. But that is to sort of give you a taste of how you can try to think through what really might be driving those figures. And then I would start asking yourselves, how might we refine our model or our thinking on this using data as part of planned clinical trials or pilots? So depending on the condition you're working in, depending on the area of care or the specialization, you might find that there's fantastic costing literature that you can do a PubMed search and you're going to find really great costs that someone else did for you in beautifully designed health economic studies, and you're going to pull them into your model and you're going to say, great, we're done. You might also find that there is very insufficient or poor quality costing literature, or maybe it is very dated. Maybe it's from the 90s. Maybe it's, costing literature that reflects outdated treatments or a previous standard of care. And so in order for you to actually put together a model that's going to work, you're going to have to figure out how you're going to address those data gaps. So that can often be done. I really encourage companies to think through, as part of their planned clinical trials, what can you fold in or add on to sort of meet some of those gaps? Or if you're establishing partnerships or pilots, what can you make sure that you get from them as data that will help inform your cost savings analysis? I see a question here from Mikhail. Do I need to partner insurance provider before making a decision to be able to get input data to do financial calculations? Where to get high-level data of their expenses? Mikhail, it can really, really vary. So this is a place where, depending on the condition that you're working in, you might be able to find it through literature. You might be able to estimate it. This is, I would say, as someone who does this as part of my profession, this is oftentimes what people are paying me to do because it's tricky. So it's, I think a great example is we will have someone who wants to partner with an insurer to get better data on expenses. But first they have to get that partnership set up. So we think through, well, like, what can we use? How do we put together a reasonable estimate? How can we, it's almost like a puzzle. So you sort of think a little bit creatively on how you're going to come up with those estimated figures if you're not able to get it from published literature. And then ideally you set up those partnerships, you set up those pilots, and you have some sort of data sharing agreement or some sort of joint research initiative that allows you to get better data. Does that help address that question?
Yes, it's clear. Thank you.
Okay. And then the next question you would be asking is how you might want to disseminate those findings or the analysis. So sometimes a blog post is enough. Sometimes you want a peer-reviewed journal article. It really depends. So I really encourage people to think through some basics of the analysis and what they want to show, what they want to demonstrate, and then come up with what I would call like a communications or publication strategy. If I had to put these on a spectrum, I would say, a blog post is something really simple, really easy. You could write that in a day. It goes up on your website or on LinkedIn. Amazing. Doesn't carry a lot of weight, doesn't carry a lot of sort of, scientific validity. You might decide that at this point in your company, you don't need that. On the other end of that spectrum, you could do a peer-reviewed journal article. Okay, so then you're really going to have to sort of have a pretty, I would say, substantial analysis, right? It's going to have to be well thought out. It's going to have to be well constructed. You're going to have some interesting data. And going through the peer review process is hard, right? It takes time. You go back and forth. There's no guarantee that you'll be accepted for publication. But you might also identify that for your business, that's really, really important for you to be able to point to that. And in between, we've got options, a white paper, a conference abstract, things like that. I see another question. Oh, just a thank you in the chat. Any other questions about next steps as you carry forward your theory of change? What is the volume of analysis that the market likes to receive in terms of amount of data? That is the million-dollar question. I would say that it can really depend. So I think one thing to understand is that statistical significance is not the same thing when we talk about health economics and outcomes research. I don't mean that statistical significance is not important. I don't mean that it's not something to consider. However, it doesn't function necessarily in the same way as it does in an RCT, in a randomized control trial, right? So when we think about sort of the volume of data or what you need, usually as a starting point, I advise companies that the minimum bar is that it needs to pass the sniff test. That's silly. It's not me, that is not a scientific term. It is intentionally vague. What do I mean by it needs to pass the sniff test? You're having conversations with insurers, with payers. You may have a model, you may have a way of calculating costs that is so intuitive, it makes so much sense, and it's so clear in terms of the logical causalities that they don't need you to go through and demonstrate this or verify this with, some sort of large economic analysis or claims-based analysis, or, looking at a health resource utilization overlay to your randomized control trial. They might not need that. They might look at that and say, yes, of course, that makes sense. It's not unusual that after a pitch, they'll go back and look at their own data. They might sort of run their own internal analyses to see if what you shared with them sort of matches what they would estimate for themselves. That I would say is the easiest. That's the simplest, bar that you're clearing. You might have a much more difficult case to make, which is that, there's not great costing data. The way that you influence cost is sort of complex or convoluted or difficult to really draw out. And in those instances, it might really benefit you to have sort of larger data sets that you can really point to. So I know that that's not a particularly clear answer, but it tends to be so specific to your solution and to the area of care that you're working with and with your theory of change. Okay. So I just have a few tips and tricks that I wanted to put out here based on doing this quite a bit that I encourage people to think about as you're going through your process. So the first one, I was going to say, don't quote me on this, but it's recorded, so it's here for posterity. I'm going to say, as a general rule of thumb, not exclusively, not always, but as a general rule of thumb, you should be looking for a minimum of single-digit millions of US dollars annually in a lives pool of 100,000. Keep in mind that particularly if you have a point solution, these insurers and payers are being bombarded with point solutions all the time. And it's an operational cost for them to adopt your solution and to do the integration and to do the rollout. And so they they may not have, a particular motivation for the condition you're working on, for the area of care that you're working on. They might be tasked with, as decision makers, for example, as a digital health unit, they might be tasked with just, helping identify the most cost-saving solutions. So I would say that your goal should be single-digit millions US dollars in a lives pool of 100,000 per year. That might mean if you have a very high prevalence of patients that are relevant for your condition, that you can have pretty low per patient cost savings. If you have a condition or a specialization that you're working on that has a very low prevalence, and so you're working with a very small number of patients, it means that your cost savings or revenue increase will need to be higher. Increased revenue is preferable to cost savings. I don't think anything more needs to be said about that. If you can, it's nice to be able to identify where savings or revenue comes from, especially from multiple sources. So one thing we didn't talk through when we talked through cost drivers is actually where within the bucket of health resources things can come, right? Is it inpatient care? Is it outpatient care? Is it pharmaceuticals? Is it diagnostics and labs? Like all of those cost categories, I think if you're able to identify where your solution influences those, are helpful to have. I think the other thing that I would point out for you is don't assume that payers fully understand the cost drivers for a specific condition or area of care. You're working deeply with your solution, you're working deeply with your patients, it makes sense to you. They might not be so familiar with it. So a lot of times when I'm working with startups to put together slides for payers, one of the first slides that we'll put together is just an overview of cost drivers for that condition or for that patient population, just so that insurers or payers can understand sort of what's the baseline, what's the status quo right now for this group. And this goes back to the comment that we had earlier, which is where do you look at that revenue timescale? So it's important to think about where that return comes from a time perspective. So it's difficult for these decision makers to look at budget impact that will only manifest years from now. So I think as much as you're able to make the case that these returns come quickly, ideally within the calendar year, it's better. And in general, if you're able to try to determine what budget lines or budgets your decision makers have control over. I have a question from Jose. How does the dissemination of findings help? It's a great question. A few ways. One, it can just help generate market traction for you, right? So if you have fantastic findings around cost savings or an economic impact, that's something that you can present at conferences. You could do a webinar about it. It might help you engage different thought leaders or champions within your field. That's one way, sort of just by getting your name out there from a publicity perspective. I think it can also help you make the case when you're in those conversations with payers to show how serious you are. So it's one thing to say, yeah, I did a back of the envelope calculation and here's what we're going to save you. Sure, if that passes the sniff test for you for the payer, great. It really may not, in which case you're going to want to be able to show them as a follow-up, we did a study on this, or we have a white paper, we have a report, here's the conference abstract that you can send to them. They know that there's validity and legitimacy to what you're doing. I can tell you from experience, they're unlikely to spend a lot of time doing a deep dive on it. They're unlikely to look at your analysis in depth and really, take it apart. And it's not that they'll never do that, but it's unusual. But they will look at it and they will understand that you have a publication or that you have a conference abstract or something like that. So I think it's a way to demonstrate to them that the analysis that you're doing around cost savings is legitimate. Not how payers relate to pilots or health economic studies conducted outside the US. They're not great. So I would say that because the US healthcare system is financed and financially incentivized in such a unique way globally, It makes it very difficult to translate economic analyses between, let's say, for example, Israel or European countries to the United States. So I know, for example, when I'm putting together costing models or analyses for my clients, I almost will never use economic sources from Europe. If they're interested in talking to European entities, great, but they oftentimes don't translate really well to the United States. One thing that we can sort of have some exceptions around is if those economic studies incorporate clinical data or epidemiological data, population level data. That stuff I can often pull in, right? So, you can look at what you can pull from those studies, but the actual figure amounts, the like translating shekels or euros into dollars within the US healthcare system, it's just really apples and oranges, unfortunately. Okay, so we're approaching time. And one thing that I wanted to leave you with was a very strong encouragement to think about your theory of change and your metrics that are related to health economics as being fully integrated into your product. Meaning, I think that you should figure out and really look at how these can be incorporated or connected to product metrics, for example, your product KPIs. I think you should be thinking about how this informs your roadmap around cost savings, revenue generating mechanisms. I just see that that companies that really integrate these two lines of work make their lives really easier because they're not looking at a separate, distinct analysis, which sort of sits in a file somewhere and they pull it up every quarter or whenever they need to update it, to go have a payer conversation. Instead, it's living and breathing within their product. So they're refining it, they're revising it, they're improving it, and it's always up to date. What that integration looks like can vary considerably based on your company. So it's hard for me to give, some more detailed concrete advice around that, but I just really encourage you to think about how they are part of one stream of work and not two distinct things. And that's what I've got. We've got time for questions. We have comments. The other thing that I will put out there, I would invite any of you, you're welcome to take a complimentary session with me if you email me. So if you're thinking through this and you want to talk about it, shoot me an email. We can find a time and I'm happy to give you a little bit of my time to just sort of bounce ideas around or be sort of a thought partner as you look at some of this thing. Other questions or comments? Thank you, Helen. That's much appreciated.
Well, I'm going to say what Helen wrote out loud. Curtis, thank you so much for an extremely clear, really to the point presentation. First of all, everyone listening, this is being recorded and you will receive a link to the recording. And I know we have a few companies who couldn't make it today and I will be making them listen to this. And I'm sure we'll be working with you in the near future. And really, I think you took a complicated topic and presented it very clearly. Thank you.
Thank you. I appreciate that. We still have some time and we still have some questions coming in. So I'm going to stop sharing my screen just so we can all see each other. And one thing that I see from you, Anat, you were talking about events and hospital reduction. Thank you for clarifying that. I would say absolutely, if you're looking at other markets, those things are relevant to the US healthcare system. So thank you for clarifying that. Really where it gets difficult to do that translation is when we're actually looking at dollar figures or cost amounts. But things around, resource utilization or adverse events, absolutely, I would say that you should feel comfortable using those back and forth between Europe and the US. The only thing to keep an eye out is whether there are some, major population differences or ways in which the healthcare system is structured that might influence that as well. I have a question from Helen. Can you make a comment about how early to talk money in meetings with investors? Helen, do you mean specifically money around cost savings and economic analysis, I'm assuming? Yes. I would say early and often. So, one of the things that I do, I work across startups and I work across funders. So when I work with startups, I help them put together these models around cost savings and economic analysis and outcomes for the purposes of their business strategy and to be able to sell to payers. I do very similar forms of analysis for funds and funders, because as you might imagine, that really affects the business potential of a company. So I think if that's a place where you can engage with investors and talk about that, it makes a very strong, a very compelling business case for what you're doing, right? You're not just talking about total addressable market. You're not making up numbers around what you're going to have, revenue per patient per month. You're saying we put a lot of deep thought into this. And so I think it can help them feel more comfortable around the business diligence of what you're doing. I think it also demonstrates as a founder some real thoughtfulness and deep thinking. Any other questions before we wrap up for today?
My question would be, if possible, and thank you for the insightful, I think, hour. I'm sure. You mentioned the economics and the very specific, unique model that the US is, and I fully acknowledge that. My ask is around the clinical studies conducted outside of the US, not for the economic module, but for the numbers, figures, and results. Are they valid enough, or then how big of a scale do we need to have that conducted in the US?
So I want to be very careful about what I say here, because it can really depend on the area that you're working and sort of what level of FDA approval or regulation you're seeking. So that is a place where if you are seeking regulatory approval, if you have a regulatory pathway within the US or European or UK markets, that is a place where you should find yourself a clinical advisor or a regulatory advisor, and they will give you that input, specifically on what sort of requirements your trials would need to have in order to withstand the scrutiny or to meet the requirements of certain regulatory bodies. That's not something I would speak to because it's outside of my wheelhouse, so I don't want to give you bad advice. I think setting aside the regulatory pathway, speaking with insurers, with payers, with decision makers, and your potential customers, clients, in my experience, they're typically pretty open and comfortable with RCTs and clinical trials that were done elsewhere. I think there's certainly a bias towards, if we're talking about American payers, I think there's absolutely a bias towards countries that they perceive to be similar to the US. Right, so Europe, UK, I think they see a fair amount of Israel. I think they're seeing more in India. So that is, whether that is fair or accurate, that is just a trend that I see. But I think from engaging with folks on clinical trials, I don't see as much skepticism around work that happens elsewhere.
Cool, thank you.
I see Nimrod here has shared some experience that might be relevant for you. I also see a question from Tal: which asset is highly valuable in the early stage and what will attract the attention of investors? Tal, can you clarify what you mean by asset?
Asset, I mean, if we talked about the data before. So I ask if that would be an asset for me because we are in an early stage, really. Or should we come with our MVP, or should we raise money just for ideation to increase our ID to a really big deal?
Yeah.
So what's your opinion?
So I don't know your company or what space you're working in exactly. I think what I can share around assets, specifically data assets and patient records assets. As a generalization, I truly believe that Israel has world-class patient data. You will almost never find that. You will not find that in the US market. So when I'm working with investors or funders and anything that is big data related, anything that is AI, this is a place where I think that Israel has a unique advantage because of the historic EHR systems that we put in place in the 90s and the interoperability requirements of the Kupot Cholim. And the fact that the Kupot Cholim through those records have access not just to claims data, but actually to, lab analysis, the actual diagnosis, things like that. You can get all of that in the United Health system.
If we try and success in the Israeli market, right? In the US, they have it's a big difference, or they see what we did in Israel, and maybe copy that to the US with adaptation.
It's hard for me to weigh in on that without knowing more information.
Right. Thank you. Sorry, that's what I can expose now.
I think that's it. I will reiterate to people again, you're welcome to reach out to me, Curtis at kingfisheradvising.com, and I'm happy to give you a complimentary session if you want to sort of brainstorm a bit or have me take a look at your theory of change. Reach out to me. This was such a pleasure. Thank you, everybody, for participating and for these really fantastic questions.
Thank you, Curtis. And we hope we can do this again soon. Thank you very much. Bye-bye.
Bye.